The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. Thank you for joining us for today's program on virtual visits, reimbursement, and operational logistics. I'm Terry McWilliams, Director and Chief Clinical Consultant here at HSG. I'm joined by Davis Creech, another HSG Director, and Kelly Humphreys, one of our specialist consultants who brings a wealth of third-party billing expertise to the presentation. Before we start the presentation, we'll address a couple of housekeeping items, including taking care of technological glitches of a frozen screen. We welcome your questions, and you can submit them at any time during the program by using the question submission option on the right side of your screen. We will answer submitted questions at the end of the presentation without identifying the names or affiliations of those who submitted them. If you do submit a question and we can't get to it during today's program, we'll be sure to answer it promptly via email. You're also welcome to reach out to me, Davis, or Kelly at any time through the contact information provided on this screen and also at the end of the presentation. There's also the option of going to our website, www.hsgadvisors.com, and contacting us through the website. The webinar recording and the actual presentation will be available on our website by the end of the day tomorrow, we hope, and can be accessed there. We're going to try this again. All right, so let's go ahead and get started with today's program by reviewing the objectives for the webinar. One objective is to try to do this in a more technically proficient manner than we have so far. To that end, we are going to try to do this, since all of us are at different locations, meaning the three presenters. We're going to try to do this without talking over each other as much as possible. And in that way, perhaps enable you all to understand the processes that must be managed to successfully implement virtual visits. We'll especially focus on the revenue cycle requirements to ensure that you can collect for the services rendered. And then just mention briefly the conditions expected that would be necessary to sustain virtual visits after the pandemic has passed us by, or at least we're on the other side of it. So just a quick background of what we mean by virtual visits. There are many definitions out there, but for our purposes today, we're going to call virtual visits a form of remote telehealth delivery in which the patient-provider interactions occur through telecommunications technology. In general, there are two major categories of interactions. One is synchronous, in which the interaction occurs in real time, and this would be a standard audio only, like telephone interaction, or video teleconferencing capability. There's also asynchronous interactions, which have time lags between responses, such as occurs with patient portal messaging, secure email messaging, or secure texting. Before we get too far, we already mentioned the telephone interactions, and that's a concept that's been embedded in office practices essentially forever. And that's in the form of what we do during and after normal business hours. So much of our on-call interactions from the office experience has always been essentially a virtual visit, deciding without laying hands on an individual what courses of action might be required. So this is just taking it to a next level and considering different applications in our current pandemic crisis. This might also be the place to point out there are many other aspects of telehealth. It's a very broad spectrum of interactions that would meet this definition. We are not in this presentation going to address some of the more traditional telemedicine aspects, but focus on office-based virtual visits in the current environment. There are many benefits to virtual visits and telehealth communications. On the patient side, much greater convenience in both the timing of the visit and travel. Individuals can select times that are convenient for them with less lost time from work and avoiding travel times. And often this also creates greater access to both primary and specialty care for the patients and at lower costs. On the provider side, also greater convenience with more flexible scheduling and a greater latitude in time management, and ideally improved access for patients. For instance, as we look at social determinants of health, one of the major barriers or impediments to office visits is transportation issues. Telehealth removes the transportation barrier. And finally, it can give providers greater access to consultants. I've experienced in the past where some consultants were perhaps somewhat reluctant to give advice by telephone because it wasn't billable. And so, they would prefer to have the patient sent to them so they can create a straight fee-for-service encounter and become reimbursed for their time and expertise. We'll talk a little bit about some of the things that are happening now that can allow that to happen and allow greater access to consultants across the board. And finally, we'll talk about the administration side of the equation. Telehealth can often give decreased cost of care and increase operational efficiencies. So with those benefits, why haven't we pursued telehealth more aggressively in the past? I alluded to what I think is probably the biggest impediment, and that's the lack of reimbursement in the fee-for-service environment. Most of our office-based interactions are predicated on the fact that you can get paid for those, and you weren't getting paid to be on the telephone or otherwise interacting with patients. This is not a new issue, and in fact, utilization of virtual visits and telehealth interactions were advocated in the 1990s during the managed care movement, and those organizations that have progressed in that movement and exist in a capitated or a full risk environment utilize this most readily because it's providing safe and effective care at the least cost. There have been issues with patient acceptance. Even with our face-to-face encounters, we hear complaints that the physician or APP did not spend adequate time in the face-to-face interaction. And this then is an extension into, boy, I didn't even get to see the physician or APP. We just talked, and that can have a bit of a barrier, especially for different generations. Provider acceptance, an issue. There are those who feel that the only way to fully interact with a patient is face-to-face, so you can have all elements of the interaction on which to base opinions and judgments, body language, facial expressions, and other elements that might not be readily apparent in some types of virtual visits. Even before HIPAA regulations, there was concern about having a secure mechanism that protects patient privacy, and that's just expanded exponentially since HIPAA requirements are now commonplace. Availability of the technology, whether it's internet connectivity or an adequately secured mechanism, has been a barrier. And then being able to use the technological capabilities in a facile fashion, not only from the provider side, but especially from the patient side. There is some concern that some of our older generations might have more difficulty, although I can tell you many of our older generations are much more facile than I am, and very expert in the use of these modalities. So the whole telehealth movement has been strongly promoted in the transition towards value-based care, and it's made some slow recent progress. That progress is accelerated by the success of some national companies who offer online services, such as American Well or Teladoc. In these instances, usually it's an upfront payment by the patient and a flat fee for service mechanism with either a discount or free service in some employee benefit packages. It's found great acceptance among the younger generations of patients and is actually a favored interaction by millennials who statistically, and I'm sorry I can't cite the studies that I've read, but the majority favor a telehealth interaction over a face-to-face office-based encounter. However, that brings us to today's situation in which virtual visits suddenly exploded with the COVID-19 pandemic. With the social distancing, canceling elective face-to-face encounters, conserving PPE resources, and the recent relaxation of regulatory restrictions and payment reimbursement, rather in a fee-for-service manner, has just allowed this to take off. And this is actually where we'll focus most of our attention today. That leads to a couple of strategic imperatives, one set based on the immediate term and the other based more toward looking to the future. So in the immediate term, the COVID-19 pandemic necessitated changes in our care delivery processes. And the response compelled the ability to, in dealing with the COVID-19 response, to virtually triage patients for illness and appropriately direct the next set of interactions or interventions. But even beyond the COVID-19 response is how do we keep our practice going and how do we meet patient needs? Especially since most practices experience a decrease in office encounters of more than 50% with the elimination of elective visits. And in utilizing the virtual visits, acute, subacute, and chronic care interactions can be continued so that patient needs can be not only anticipated but met. Continuing patient interactions through telehealth communications or virtual visits can also allow practices to keep all of their staff more fully engaged and utilized in a time of decreased face-to-face encounters. And these encounters now permit sources of patient care revenue to offset the losses related to canceled visits and continued overhead accrual. If we're going to do this, though, we should do it well and do it as well as we can. And so developing operational processes to allow our practices and our patients to benefit from virtual care provision is required. And this may actually necessitate a relook at how we use our patient portal capabilities. And we may need to expand portal permissions or consider other as yet utilized aspects of the patient portal that were not pursued due to provider and other barriers. In the longer term, as we look beyond the COVID-19 pandemic, I don't think that there's anyone that thinks that the genie is going to be put back in the bottle. Now that we've, that virtual care has exploded and telehealth capabilities have really found a place in daily health care, it's going to be difficult to go back. But there are going to be some unique situations that were relaxed in the COVID-19 timeframe that won't be there in the future. So as we look to the future, currently, I think we should identify processes that are required to sustain virtual care initiatives in the future and use it to augment patient access to the practice. One of the aspects is determining whether secure platforms are needed, because the whole thing of being able to use Zoom and Skype during the pandemic is surely going to go away once the national emergency is passed. There are EMR-based systems. The major systems like Epic and Cerner have that capability, but they're felt not to be as robust or sophisticated as some of the separate systems that might be more elegant and more user-friendly. They do come at a cost, and so that must be factored into future budgets. as well as whether a business associate agreement needs to be in place to meet HIPAA requirements. As we look to the future, we can build on current successes and look to eliminate or mitigate barriers, prior barriers or historic barriers to virtual visits and telehealth utilization, and chronically market these services to patients and figure out how in our scheduling and productivity analyses we make this a chronic service that's chronically marketed to our patients. There may need to be alternative staffing models that we hadn't considered before to fully maximize and perpetuate virtual care, and exploring options for long-term reimbursement, especially with commercial insurers. As we get through some of the things in the presentation today, a lot of the acute phase aspects may fade or be eliminated. So looking at ongoing reimbursement and making a good business case for continuing the service becomes necessary. As we move toward full risk management, this will be a mechanism to make it more profitable in our per member per month allocations. So it will be something that if we do it well, it will serve us well in the future as we look at bending the cost curve. And then finally, how this impacts our provider compensation models, because there needs to be incentives to keep us going and to align with the organizational objectives to expand the service over the long term. So let's turn our attention to some of the more recent developments in the virtual visit and telehealth area. The most notable of which and the announcement that really catalyzed this whole process occurred on March 17th when CMS announced that it would expand reimbursement for telehealth interactions for Medicare beneficiaries. These are Medicare fee-for-service beneficiaries during the pandemic. This was the day before the national announcement occurred about eliminating non-urgent encounters and really ratcheting back our face-to-face interaction to maximize social distancing. The action was designed to permit access to care for patients who need it and to offset projected revenue losses on the part of the healthcare providers based on the elimination of non-elective encounters. In the past, CMS only reimbursed for virtual encounters if they occurred in designated rural environments and the patient was physically present in a healthcare facility during the interaction. So this was the traditional telemedicine type of encounter that needed multiple parameters and of which many of us did not avail ourselves of. The announcement expanded the types of interactions and included many hospital, skilled nursing facility, and office encounters over a vast number of CPT codes. The full list is in the link there, and the list is rather extensive, but it would also allow you to see what capabilities will be reimbursed under this new announcement. The reimbursement rates, notably, are at the standard face-to-face value, so there's not a deduction for these rates, and the RVU credit also is at the standard face-to-face value. So this expansion of coverage for Medicare telehealth visit only applies during the COVID-19 national emergency. And again, will likely go away unless something unforeseen happens as the emergency is lifted. To meet the requirements, providers must use interactive audio and/or video telecommunication systems that permit real-time communication between the provider and the patient at home. So far, the provider's not able to be at home. The provider still needs to be in an office setting, although that may change if this situation continues. Any non-public facing telecommunications technology could be used. So applications like Zoom and Skype and Facebook Messenger can be utilized for this. The public facing telecommunications like Facebook Live, Twitch, and TikTok cannot be used. I had no idea what that meant. So I put those examples in there thinking that maybe some of you would be like me and not know exactly what um, public facing versus non-public facing meant. Should be noted that Medicare copays and deductibles apply to each of these virtual encounters, although unlike other situations, providers are allowed the discretion to either reduce copays and fees or waive them entirely. This is in recognition of all the hardships that are going on, so providers are allowed to waive fees, unlike normal circumstances. And although this interaction is intended to be for established patients, without so much as saying it's okay to be used for new patients, CMS announced that HHS would not audit the process, meaning nobody's going to come in and make sure you had an established relationship prior to using the telecommunications pathway for care. So eligible for provider types include those listed. Most of these are the credentialed providers under Medicare. The code in the claim submission process, the code is the encounter that, or excuse me, is the one that would be used for the encounter per the usual process, with a modifier of O2 added to indicate telehealth. And there's a CMS fact sheet that goes over a lot of these aspects and can provide much more detail. But I think at this point, maybe I'll be quiet for a second and ask Kelly for some comments about this aspect of the Medicare telehealth expansion.
Thank you. The telehealth expansion into Medicare is changing on a daily basis. And the one thing that I encourage everyone to ensure is that you're documenting all of the appropriate steps in a telehealth visit to support what we're billing. One of the key components of that now is to document how you're communicating with that provider. So you want to ensure that when you have a provider involved in a telehealth visit, yes, you may be billing in 99213. It's not going to look incredibly different in that respect, but you need to make sure that you've got the phrases in there that this is being conducted via telehealth and if you're using a standalone communication system, name it. You need to document that you have received verbal confirmation from your patient to conduct the visit via telehealth. And that's something that is incredibly important at this point, is that patients need to understand that it's a telehealth visit and it's a visit. One of the things that I've ran into is patients who say, well, I thought I was just, having a call with my doctor. No, this is an actual visit. You're going to see a charge for that on your beneficiary notice or your Medicare Advantage notice. And you have to explain to the patient that they need to be aware that conducting this visit over an audio-visual telecommunication tool, that you will take the steps necessary to ensure HIPAA compliance, but they need to be aware that they're speaking to you through their computer, through their phone, through Facebook Messenger, and that if there are people standing around them, et cetera, that you just need to make sure that you're getting the patient's consent for that.
Thanks, Kelly. And all those are key practical issues in offering the service and ensuring that even though CMS is not auditing now, just in case there's any blowback in the future, that everything's above board and handled well. One thing to mention is CMS promulgated this expansion related to Medicare fee-for-service beneficiaries. Both CMS and I think all state governments are urging their commercial insurers to provide similar coverages, and this includes Medicare Advantage coverage. There's been a lot of debate and questions about, are the things that CMS do, the things that CMS are doing, are they equally applicable to Medicare Advantage? And since commercial insurers are the primary intermediaries for the Medicare Advantage plans, CMS can't dictate exactly what they do, except they're supposed to provide for the standard Medicare benefits as a rule. Since this is not a standard Medicare benefit, it's unclear whether this can be a forced issue with others. So we would recommend checking with state Medicaid and individual local payers for covered services and associated modifiers. I know one of the local payers in Rhode Island, for instance, requests a modifier of 1 or 11 in their submissions. So please check with your local payers to make sure for things other than Medicare fee-for-service beneficiaries what the coverage situations are like. Kelly, did I say that okay?
I think that we're interchanging modifier with place of service. So the place of service of 11 is office and 02 is telehealth, and you do need to check with each individual payer to determine what their requirements and expectations are on those claims.
Thanks, Kelly. All right, the other thing Medicare did in its announcement on March 17th was to re-emphasize telehealth coverages that were set out and promulgated in the, whoops, that's supposed to be 2019. My dyslexia must be kicking in. And 2020 Medicare physician fee schedule final rules. And in those final rules, CMS indicated its intent to try to move the care delivery system toward a full risk mentality, but provide integral fee-for-service like reimbursement and workload credit en route. The important thing to note about these next areas that we're going to talk about, and they're listed on the slide, is that these were valid before the COVID-19 national emergency and will be valid after the COVID-19 national emergency. And the reason I'm mentioning and emphasizing it so much is that in our interactions with clients over the past year, most indicated they had no idea that CMS had put out and is paying for services that it previously did not reimburse nor give workload credit for, and had not moved to look at these as part of their daily operations. So we're going to go through these not to belabor them, but mostly because our experience indicated that most of our client organizations weren't aware of their existence, and these will still be available to us even after we recover from the COVID-19 national emergency. So the first of these is as entitled or known as virtual check-ins. This was established last year and was effective from January 1st, 2019, and applies only to established patients. You notice that we mentioned before in the expansion of services announced a couple of weeks ago that it was intended to apply only to established patients. This truly only applies to established patients. It must be a patient-initiated contact, usually by telephone, although practices are allowed to educate all their beneficiaries about the availability and the requirements, even with the telephone consultation process. So it's not something that has to be a written consent on file. It's just a patient verbal consent that's documented in the medical record. And the education and acceptance can occur even with the interaction at hand. The interaction must be completed by a credentialed provider. It cannot be completed by your nurse or medical assistant. So it has to have involvement by a credentialed provider. The Medicare copays and deductibles apply, as Kelly just mentioned. But providers can respond via any modality, such as telephone, secure text messaging, secure email, or through a patient portal. There are two caveats related to this, two additional caveats related to this. The first is this virtual check-in or interaction cannot originate from an E&M service that occurred in the previous 7 days, nor can it lead to an E&M service or procedure within the next 24 hours or whatever the soonest available next appointment is. So this really has to stand on its own. In my mind, this is what the typical telephone consult used to be. You know, you touch base, you give advice, you set a plan of care, and that stands on its own. And that's really what I think the design of the virtual check-in is. These interactions are coded as a G2012 and assumes 5 to 10 minutes of medical discussion by a credentialed provider. To my knowledge, you don't have to document the time spent, but that's what the underlying assumption is. Again, notice it's by a credentialed provider, Medicare credentialed provider, not by a support staff member. If we look at the national Medicare allowable for this is $14.80. Again, that will vary by region. And you get an RVU credit of 0.25 for the interaction. Kelly, any comments about virtual check-ins, or Davis?
This is Kelly. I don't want to contradict you, but the virtual check-ins, although it doesn't specify, it's always good practice and to document the time, only because there are other areas that do require time documentation.
Absolutely, and as we get to some of these coming up, it is necessary to document the total time through this, and maybe we can permit a little bit of a digression. You know, as we get into what's anticipated coming in 2021, where time itself can be an indicator of complexity of interaction, I think. And I'd be interested in your advice, Kelly. I think it's going to be more and more important, even if we're not billing according to time, that we start just getting used to documenting it in our interactions.
I agree. There's a lot of challenges in today's current model of seeing patients face-to-face in the office and spending extended periods of time with them on when you can bill on time and when you can't. It's always a good idea to document the time of the visit if there's any time requirements related to that visit at all.
All right. The next type of encounter are called e-visits. This came out in this year's physician fee schedule final rule. And so this was able to be in place as of January 1st of this year. And it's essentially the same thing as a virtual check-in, although it's initiated and conducted through the online patient portal. Again, initiated by the patient through the portal, provider responds via the portal. All the things that apply to the virtual check-in applies to this. A difference between the e-visit and the virtual check-in is that the e-visit claim submission process is tiered, and you get tiered payments based on the cumulative time expended on this over a 7-day period. In my mind, one of the reasons that's important is when we first started thinking about patient encounters through email, or in this case the portal, was the whole concept of when does it start and when does it end. So in this area, it starts whenever the patient initiates contact, and the time frame for cumulative time expended is for a 7-day period from that moment forward. And Kelly, I'll ask for clarification in a second, but coding is based on provider type, as noted on the next slide. So for those individuals who may independently bill Medicare for an E&M visits, like physicians, APRNs, PAs, there's a set of codes, 99421 to 423, each of which has a different amount of cumulative time during that 7-day window, 5 to 10 minutes, 11 to 20 minutes, and 21 or more minutes, respectively. There's also a set of codes for clinicians who may not independently bill for E&M visits, like physical and occupational therapists, speech therapists, and clinical psychologists. And so they have a series of G codes, 2061 to 63, with the same tiered time sequences that are able to be billed. And each of these are reimbursed differently. So if we look at the codes and the rates and the RVU credit, it recognizes the differences in time spent. Anything we missed on this area, Kelly?
No, I don't think so.
Okay, good deal. Also from 2019, the store and forward communication. This is where the patient does a video recording or submits images through an asynchronous transmission of healthcare information, like the portal, and permits reimbursement when the provider analyzes the photo or the video to evaluate the patient's status and assess whether a visit is needed or develop a plan of care. This isn't that different from teledermatology, in my opinion. There's a picture of this thing, and the patient submits it and says, "So, do I need to do something about this thing?" And it could be simply answered if it's something as recognizable as, for instance, a cherry angioma, but may need to lead to further assessment based on the appearance and any suspicion of something that could be worse than what it would appear on face value. All the requirements and parameters of the virtual check-in apply, as we talked about for e-visits. This has just a single code and single reimbursement rate and RVU credit for this element. We mentioned before about interprofessional internet consultation. This is where, again, effective since last year, but this allows reimbursement for telephonic, internet-based, or EHR-based interprofessional consultation when the treating provider requests the opinion or advice of a consulting provider with specialty expertise to assist with the diagnosis or management of a patient's problem, and that encounter can be safely undertaken without the need for face-to-face patient contact with a consulting provider. This is another time-dependent code with the first four of the codes listed by duration of the interaction, and the fifth code differentiated by whether the consultant provides a written report to the requesting provider along with at least 5 minutes of consultative time. The interprofessional internet consultation does require a patient's verbal consent that's documented in the record, and Medicare copays and deductibles apply. It actually dawned on me, Kelly, when you were talking before, and not only, even if you waive the copay for the visit under the current circumstances, the patient would still get an EOB for this, would they not? And in the current atmosphere of being concerned about Medicare fraud, I know that some patients have questioned charges on their EOB. So it's almost doubly important that the patient's aware that Medicare will be billed for this interaction, and their copay or deductible would apply.
Agreed. I think that that's extremely important. And again, that's why I go back to making sure that we do have that very clearly explained to and documented in a patient chart. And as this relates to commercial payers, you will find that there is a lot of language in the commercial payer regs that indicate copays and deductibles are waived. If you read the fine print, it's waived as it relates to COVID-19 diagnosis and treatment. So it doesn't waive copays and deductibles from a managed care and commercial payer standpoint across the board.
Ooh, good point. Finishing up this category, there is also the ability for the consulting provider to request further information from the treating provider. And in that circumstance, there's a different code that applies and a 30-minute time consideration. Same elements for this type of code, meaning the reciprocal payment for exchange of information in a reverse pattern than the traditional from referring to consulting. This is now consulting to referring. Here are the payments and RVU credits for those. Again, the first four escalating into the written documentation submission, and then equal payments for comments, the reciprocal payments. In 2019, CMS authorized reimbursement for 3 scenarios related to chronic care remote physiologic monitoring. One for setting up and educating the patient about the monitoring device and utilization, and that's only eligible to be reported once at the onset of utilization of the remote monitoring service. And this tends to be more commonly support staff generated as opposed to provider generated, but there is a one-time eligibility for that service. There then follows a monthly supply of devices for daily recordings or programmed alerts, and then the provider interaction about analyzing the remote monitoring and developing treatment management decisions based on the monitored data. As would be expected, there's no RVU credit for the first 2 circumstances, but there is RVU credit for the third, which involves physician decision, or excuse me, provider decision making. But they're now this expands the ability to be reimbursed for remote physiological monitoring. And then finally, this year, that element was applied to self-measured blood pressure treatment plan support, and similar types of associated codes. The first is self-measured blood pressure using a device validated for clinical accuracy, and includes patient education and training and device calibration, usually at the outset and periodically thereafter. The second is separate self-measurements, and this is very detailed, but 2 readings, 1 minute apart, twice daily over a 30-day period with a minimum of 12 readings. The collected data is reported by the patient to the caregiver, or caregiver to the provider, excuse me. And then within the medical record, report of average systolic and diastolic pressures and subsequent communication of the treatment plan to the patient. So often we would have patients do home blood pressure monitoring, bring in all the readings, sit down with them, analyze trends over time, and develop a treatment plan based on the readings. This allows it to all happen remotely and for reimbursement and workload credit. The caveats for this one, for this category, is it cannot be in the same calendar month as formal ambulatory blood pressure monitoring, and it cannot be reported in conjunction with the remote monitoring codes that we just talked about. There is credit for the provider analysis, evaluation, and treatment plan. There's not workload credit for setting it up, which would be expected, but there is payment for your support staff efforts to getting the blood pressure plan going and making sure the device is accurate and calibrated. So from our perspective, virtual visits offer immediate care delivery advantages to provide needed patient care interactions in a safe and acceptable manner, to engage currently underutilized provider and support staff in worthwhile care initiatives in a safe environment with all of the aspects of COVID-19 pandemic upon us, and can generate revenues for the services rendered. As we look to longer term alternatives to care, it can continue to be utilized to provide needed care through a mutually convenient and secure mechanism. We would recommend you explore the future options now, both in the operational status, but also in looking at a platform that might be more acceptable and secure for long-term use, and enter BAAs now if necessary to meet HIPAA requirements. It can be utilized to expand access to practice services, almost like extended hours, and expand access to patients. We can engage patients in a manner that's most acceptable to them, especially as we look at generational differences of preferences. And we can safely deliver care in the most cost-effective manner as we prepare for full risk contracting. With that, that concludes our formal presentation. I'll ask both Davis and Kelly if they have any comments here at the conclusion before we look at taking questions.
I want to save some, this is Davis, I want to save some time for questions, obviously, but Kelly, you may want to talk about what, if any, changes long-term this means for operators in the offices, the directors, from a staffing standpoint. How is staffing affected as we move forward into maybe this new environment?
That's a really good question, Davis. One of the things that I think that directors, managers need to be aware of is what kind of volume can we handle? Obviously, as our current situation continues and we think it's going to be another week and then it's another 2 weeks and another month, more and more people are going to be anxiously awaiting an office visit. And how can you manage your providers and your staff and the resources that you have, the electronic resources, to have these patients seen in the most effective way possible? One of the things that I have suggested and have implemented in some of my practices is to have the front desk staff, although the patient has to initiate some of these services, the practice can still contact the patient and make them aware the services are available. So you have patients who are canceling because they don't want to come into the office, and they're a patient who's getting a 6-month checkup and they're a pretty stable patient. There's some labs to review that they had done after their last visit. Have your staff, your front desk staff, your registration people reach out to those patients and encourage them to participate in a telehealth visit. That will keep those patients healthier. It will give them what they need, and it will help to facilitate that from a staffing perspective. What we don't want to do is unnecessarily shorten hours in practices, lay people off, and we don't want to be inundated 3 months from now and have waiting lists so long that patients can't get in to see their providers.
Excellent points. So we do have a couple of questions submitted. The first, and for some reason I can only see a line at a time, so bear with me. The first question is, and Kelly, I'll refer this to you. Does this virtual visit apply to FQHCs, especially after the emergency pandemic rules end?
The rural health and FQHC rules have just recently, and by recently in today's environment in the last few days, been updated to provide for a specific code to bill as the designated the designating site of service. I'm frantically looking to see if I can pull that actual reg up, because there is a code for the FQHCs to use. I'm looking for that if we want to go to the next question, and I'll let you know when I find that.
Yeah, I was thinking about that, and I was trying to screen the next question, so I apologize for that long pause. But the question is a telehealth visit billable if the video on the patient ends and freezes or drops during the visit? I'm going to go out on a bit of a limb and say that, my understanding in reading everything is that you have to complete the interaction. So, it would be a matter of doing what it would take to complete the interaction, come to a conclusion, and finalize. So if there isn't an ability to call the patient, continue it in another fashion, I think you need to complete the interaction in order to be able to bill for it. And I don't think that's too broad of a limb or too narrow, thin of a limb to go out on, because it is designed that it's a completed patient interaction. We'll see if Kelly has any comments on that when we get her back. What is the anticipation?
Yeah, I'm here.
Oh, sorry.
I agree with you.
Yeah.
I would, there's a lot of areas that we have folks who aren't technology savvy. We have drops in cell signals, et cetera. And in those circumstances, I would agree that we need to complete that visit. And my suggestion would be is just to attempt to reconnect and continue the visit and complete it.
The next question submitted is, what is the anticipation of putting back in the rural setting requirement? And again, my read on the regulatory shift was this is currently anticipated to, or the expansion is currently anticipated to only last during the national emergency. I think the anticipation is that the expanded telehealth piece that's covering just about everything as a straight face-to-face encounter would be covered will go away, short of a different regulatory change in the future. That's one of the reasons we were trying to emphasize the difference between the March 17th announcement and the categories of interactions that were put out in the 2019 and 2020 physician fee schedule final rules, because those will be perpetuated. I think CMS will go back to the drawing board and figure out where their future regulatory emphasis will lie. But according to what's out there now, they fully intend to go back to business as usual once the national emergency is declared closed. The next question is, do you think the relaxation of where a provider and patient initiate a visit will stay the same or go back to not being available from the patient's home? Ooh. I'll take a shot at conjecture because it's purely conjecture. Since the expansion of services that we were talking about is only during the pandemic, I think it's going to go back to the way it was unless there's a regulatory change that allows these to be essentially home visits. I think, again, back to the genie in the bottle kind of analogy, I think that CMS will look long and hard at what their telehealth regulations might need to look like in this day and age. And I think personally that they're likely to come out with some new parameters for the future. But the best we can say right now is when the pandemic national emergency is officially concluded, we'd be back to business as it used to be. Do you guys have any other impressions of that?
This is Kelly. I don't disagree with you. I think it's going to be, I think that this particular situation is going to expand the public's education on what telehealth services can be. And I think that it's going to be a very high-level discussion throughout the next couple of years on how we're going to get this rolled out and it be more available in more areas. I know I, for one, had my first telehealth visit myself a few weeks ago, and it was incredibly convenient, and it was before the pandemic even occurred. And it's like, why haven't I been doing this? And I think that there's going to be more and more people who look at it that way and who push for legislation to change the telehealth rules. I don't think it's going to come anytime in the next month, but I do think that we'll see it over the course of the next few years. I did find the HCPCS code for the rural health and the federally qualified health centers. It's G0071. And that's to include the services reflected for CPT codes 99421 through 99423.
Thanks, Kelly. The next question from the group is, do we know if any of the virtual visit areas are applicable to PEDS, i.e. have commercial payers agreed to pay for PEDS? I mean, the easiest thing to say is any of the dual eligibles would be eligible for this just based on the Medicare part, right, Kelly? And then it's
right, and there, I'm sorry, go ahead.
No, it was a terrible second thought. But, you know, we mentioned talking with local insurers to find out how it applies, you know, to the non-Medicare fee-for-service individual. And I was going to go back to that. So I apologize for cutting into your response.
No, that's okay. The commercial payer documentation that I have read does not specify any carve out for any specific specialty that uses the E&M codes. So 99212, 9921314, et cetera. There is nothing that says a pediatric provider can't use those, because from a logical standpoint, if you take a 10-month-old into the doctor, that 10-month-old's not conducting that visit, the parent is. So I haven't seen anything contrary with pediatrics for those types of visits.
Next question is, are we seeing telehealth for all types of visits? This individual states that he or she knows some providers do not think telehealth is good medicine in some cases. So I'll go back. I'll answer first, and I'll go back to, you know, we mentioned one of the barriers is from the provider standpoint, and I know a number of providers personally who ironically have no difficulty with telephonic interactions while on call and giving advice, yet feel that anything other than a face-to-face encounter is not good medicine. And when confronted with, well, what about the advice you gave over the phone last night? And it's, well, that's different. And so, you know, I think there will still be some provider pushback, which gets back to, you know, the penetrance of this after the COVID-19 situation fades. I think there will still be barriers on the provider side, still barriers on the patient side, and look at this as, well, that's what we had to do during the pandemic, but not really find the applicability for long term. I personally think that the numbers of those individuals will have decreased over time and will continue to decrease over time. Having said that, there are types of interactions that are very well or would be very well designed to be safely and effectively handled through a telehealth interaction. You know, we could probably list a number of these just off the top of our head if we thought about it for more than a minute. But, you know, when we bring patients back to just to discuss lab results that could have been done in a different fashion, but we brought them back for a face-to-face encounter because we get paid in a fee-for-service environment, that can clearly be done in a virtual fashion. Similarly, much of our chronic care for conditions like hypothyroidism, intermittent visits for diabetes, where we look at glucose monitoring and glucose control, there can be any number of kinds of interactions that do not require laying of hands, but could be conducted in a audiovisual teleconferencing manner and be very well conducted. So I think a lot of it is going to come back to clinical judgment, because there are some things where you just need to lay hands. Just as some of our calls come in and say, "Yep, you need to come in so we can see you." You know, I think the same will apply. Do you guys disagree on that?
I know that there are payers out there who, as of March 15th, did not cover telehealth in any way, fame, fortune, no way. And today, those payers have gone back and retracted those non-coverage and implemented telehealth services to the extent of Medicare. And one of the things that I would suggest for everyone on the call to check into is your state parity laws. The state that I am has a parity law that indicates if you're going to do business in the state of Indiana and provide healthcare coverage, you have to provide telehealth services. And there's lots of different caveats within the law, but that's one of the statements in the law. And our governor has spoken out and said, if you're doing business here, you are covering telehealth. So I think it's important that everyone knows what those laws look like in their state. And if indeed you get into a situation where there's something not being covered, to go back to that particular reference and an appeal, especially where we are today, and attempt to get that paid.
All right, there is a question about sending out the slide deck and whether we'll send it out for use. I didn't clarify with our marketing person, who actually we're in between marketing people right now. Normally we would send out to everyone who signed up on the, who signed up as participants. We would go ahead and send it out. I'll get with them, and we'll at least, especially, I think one of the things that we were doing for those who said they couldn't attend but wanted slides is we will at least send a link that once this is posted on our website, we'll send a link, and that will have both the audio recording and the actual presentation available. So we'll do one or the other, and I apologize that I didn't check with our marketing folks before coming on the call. The next question actually looks like a comment. I agree with Kelly. I think the public will demand the option of continued expanded coverage or different coverage. It's good medicine to keep patients out of the hospital if possible and get them help if they do not have transportation, et cetera. So there's a vote of confidence in your answer, Kelly.
Thank you.
And that looks like all of the questions for today. So I want to thank my co-presenters, Davis Creech and Kelly Humphreys, for being with us today and lending their expertise in the development of our presentation, but also in its execution. And I'd like to thank everybody that signed up and attended today and participated. As we mentioned, please feel free to reach out to us if you have one of those V8 moments. Oh, I wish I would have asked. Please feel free to contact us directly to discuss anything related to this presentation in further detail, ask any questions or make comments. And we again think that this will be posted on our website. We hope by the end of the day tomorrow, and will be available for on-demand viewing and sharing. And again, we'll either send you the presentation directly or send you the link to the website where it'll be posted. We hope that you found today's presentation of value, and we hope you join us for our next in our webinar events. So thank you very much. Have a great day. Stay safe out there and be healthy. Thank you all.